I'm Wes Jackson. I am a former rural family physician. I worked as a GP anesthetist for more than 20 years prior to starting this program. I'm currently an assistant professor in the Department of Family Medicine here in Calgary. I have an urban practice now, which not as good as rural, but it's good. And I spend about half my time working on this program. So our program is a distributed program with probably about 1,500 kilometers is our furthest site. We run in the third year of a 3-year program, so the final year of our program. Students go to the sites for 9 months and spend their entire time there. They're provided with housing and computers and so on. We have weekly academic sessions where they contact each other, and many of these sessions are put on by the students themselves. Well, our program is unique in the sense that it's the final year of the medical school, which is different. Most programs run in the third or 4 years, so we run in the final one. So it's unique in the sense that our exam procedures we examine the students before they're actually finished. I think what draws students to the program, though, is the opportunity to be with preceptors who do multiple things. They're multifaceted. The students also like the opportunity to be the first person to assess an undifferentiated patient. They become involved in their communities. They become an essential part of the healthcare team, which for this type of learner is an ideal situation. They also are able to help guide their own educational path, if you will. We give them signposts that they're supposed to come to, and then they take the path that they wish to get there. We kind of call our whole scheduling system a system of K-order. In other words, it's chaos, but we have an order to it. So I think those three things, being part of a team, being able to help or to at least guide their own education, and to be to have the opportunities to be first assessment of an undifferentiated patient, are things that attract the students. I think the most important thing that we've done, in fact, we're doing something different this year. We're going into an urban site, but still basing the experience in family medicine. And what we've done in order to do that is to talk to the local people, to find out what they believe their needs are, and to use their resources before you build your program. And essentially, you're building a program around the local resources instead of what you might think would be best for that area. And as we do that, you get much more success, much more buy-in, and probably a better program. Because it's in a distributed model like this, you cannot have a completely centrally mandated curriculum. It needs to be modified to meet the needs of the local people. Yeah. Other things, I've done a couple other things that are a bit different too. We actually have supplied our preceptors all with iPads, and so we communicate with a centrally located database that is updated, well, at least weekly, and then automatically syncs to their iPad. So they know what's going on in the program within minutes of me knowing it. And also they've got textbooks and apps and so on that we use to keep them updated. So that's been really good. And we also have preceptor development. I think you need to look at that early, because one of the things that I found with the preceptors, they felt that because the students were with them as long as they were, they felt much more responsibility for teaching. And so then they felt that they didn't really have the tools in order to do so. And so we actually developed an online preceptor development program that we've run a couple of times now that's been very useful for the preceptors, mostly to validate the skills that they have, but also teach them a few more.